Caucasians. And what you can see here is she found no difference in survival across ethnicities. Now, this study was conducted in a center of universal healthcare access. So this would suggest that in other centers, notably the United States, ethnicity is less likely to be the proxy for poor survival, but rather to be a surrogate measure of access to care. A third important determinant of risk of developing systemic sclerosis are environmental risk factors. Hannah Alamari recently published a beautiful systematic review looking at environmental risk for developing systemic sclerosis. It is increasingly recognized that a number of drugs, notably chemotherapeutic agents, can induce a systemic sclerosis-like disease. There is also an increasing body of evidence to suggest dysbiosis in the gut microbiome leading to the development of systemic sclerosis. And then, of course, there are a number of known environmental risk factors. These include asbestos, epoxy resins, welding fumes, organic solvents, pesticides, and heavy metals. An increasing area of scholarly research is the influence of autoantibodies. Khaloud Al-Mabdi did a nice review looking at the role of autoantibodies in systemic sclerosis. The traditional teaching is that there are really two systemic sclerosis-specific autoantibodies, centromere and SCL70, and these antibodies tend to be stable over time. Well, Dr. Al-Mabdi's review would suggest otherwise. We are now realizing, with access to an advanced scleroderma autoantibody profile, that in fact, people with systemic sclerosis can have more than one autoantibody, just like people with lupus. Second, if you have a patient with primary Raynaud phenomenon who has the presence of any one of these advanced scleroderma autoantibodies, they are at increased risk of developing systemic sclerosis. And finally, these autoantibodies are predictive markers of those who are at increased risk for developing scleroderma renal crisis, myositis, interstitial lung disease, and cardiac involvement. Another provocative line of inquiry relates to the role of radiation and the development of systemic sclerosis. If you speak to many radiation oncologists, they are reticent to offer a scleroderma patient radiation therapy for the treatment of their cancer due to concerns of making scleroderma worse. Dr. Ausa Boabat did a review of the literature, and he found that people with scleroderma have the same risks for the early and late toxicities that we see with radiation therapy. That is erythema, dermatitis, diarrhea, anemia, etc. But what he also found was that most patients with scleroderma do not have worsening of their scleroderma secondary to radiation therapy. So as a result, his paper does not support scleroderma being a contraindication to radiotherapy. I share this with you so that you may be an advocate for your patients. If you have a scleroderma patient who develops cancer and radiation therapy would normally be on the menu of options for them, here is a chance for you to help advocate for your patient and that radiation therapy may be used to treat their cancer. So now let's shift to evolving concepts around preclinical and early disease. Many of us see referrals for people who have a positive anti-nuclear antibody. We do not consider this to be pathogenic. We sort of think of this as benign autoimmunity in 10 to 15% of the general population. A number of those people will then go on to develop clinical signs and symptoms, and once they have 2 or 3 symptoms, we call them undifferentiated connective tissue disease. But in the rheumatology research world, there is now an increasing shift towards preclinical and early disease. Walid Hafiz and Rawad Nouri reported an interesting study looking at the role of fatigue. They found that in people who are ANA positive, those who have undifferentiated connective tissue disease, and those who have systemic autoimmune rheumatic disease, fatigue is common. Furthermore, fatigue does not correlate with measures of inflammation, that is, type 1 interferon, IL-1 beta, IL-6, or TNF-alpha. Furthermore, they demonstrate that fatigue does not predict disease progression. We should take assurance in these findings, such that if you see a patient with a positive ANA or undifferentiated connective tissue disease and they report considerable fatigue, we can feel reassured that they are unlikely to develop a systemic autoimmune rheumatic disease. Hannah Alamari further extended this line of inquiry where she did a retrospective cohort study of 200 people who were ANA positive or had undifferentiated connective tissue disease. And in the short term, over 2 years, she found that the majority, 89%, do not progress, whereas a small proportion, 11%, do progress to a systemic autoimmune rheumatic disease. Among the progressors, the most common, 48%, progress to lupus, whereas 22% progress to Sjogren's disease, 13% to systemic sclerosis, and 4% to rheumatoid arthritis. Now, among those who are destined to progress to systemic sclerosis, we now have the VDOS criteria, the very early diagnosis of systemic sclerosis. This could be considered a form of pre-scleroderma. Using these criteria, there are 3 items: Raynaud phenomenon, puffy fingers, and anti-nuclear antibodies. If present, we look at step 2, the presence of abnormal nail fold capillaries or scleroderma-specific antibodies, that is anti-centromere antibodies or anti-topoisomerase I antibodies. The Italian group subsequently demonstrated that if someone has the presence of the VDOS criteria, 94.1% of them will progress to established systemic sclerosis. So now let's move on to evolving concepts beyond fibrosis, that is vasculopathy. When we think about the classical teaching around systemic sclerosis, there are 4 domains: immune activation with inflammation, vasculopathy, but the disease is characterized by fibrosis. It's inherent in the name scleroderma. However, there are several lines of evidence that suggest that in fact, systemic sclerosis is inherently a vascular disease. We know that many, if not all, patients will develop Raynaud phenomenon years or decades before the establishment of systemic sclerosis. They will have a prolonged silent phase. Some of these patients will never go on to develop fibrotic manifestations. So that has shifted our thinking such that we now consider systemic sclerosis a predominantly vasculopathic disease in which some of the patients will develop important fibrotic manifestations. And this is evident in the ACR-EULAR classification criteria, of which I was the architect. You can see that there are many more vasculopathic manifestations: fingertip lesions with digital ulcers or pitting scars, telangiectasia, abnormal nail fold capillaries, pulmonary arterial hypertension, and Raynaud phenomenon. So when we think about Raynaud phenomenon, we do not generally treat it unless they are symptomatic or have digital ulceration or gangrene. When we counsel the patient, we usually start with the non-pharmacologic management strategies, that is keeping their whole body warm and using appropriate gloves, footwear, or hand warmers. We generally counsel them on the avoidance of caffeine. I tell patients to avoid any brown liquids, coffee, tea, colas, hot chocolate, because they all contain caffeine. We often counsel the patient on smoking cessation, also the avoidance of sympathomimetic drugs, that is over-the-counter cough and cold preparations, as decongestants, amphetamines, and ephedra can all cause peripheral vasoconstriction. With regards to the pharmacologic management, I often try to propose a cost-effective approach. That is, start with the drugs that have the highest evidence base and the lowest cost, and then move up from there. So we know that calcium channel blockers are moderately effective for reducing both the frequency and the severity of attacks. Not all calcium channel blockers, however, are created equally. Nifedipine, amlodipine, diltiazem, felodipine, nizoldipine, and isradipine are thought to be superior to verapamil and nicardipine. If insufficient, one might consider topical nitrates. There has been one study to suggest the utility of alpha agonists, as prazosin has been shown to have a modest effect on Raynaud phenomenon. There has been one clinical trial to demonstrate the efficacy of losartan in the reduction of severity and frequency of Raynaud phenomenon. Increasingly, we're using phosphodiesterase inhibitors, that is sildenafil or its competing drug Cialis. These drugs are available both as oral and topical formulations. Bosentan, an endothelin receptor antagonist, has been demonstrated in a clinical trial to prevent the development of digital ulcerations, but not so great for the treatment of current ulcers. Hannah Alamari recently published a systematic review and meta-analysis looking at the efficacy and tolerability of prostaglandin analogs in treating scleroderma-associated Raynaud phenomenon, ulceration, and gangrene. And she demonstrated that prostaglandin analogs confer a significant benefit on pain severity and do not have worse tolerability relative to comparator drugs. I share with you some natural therapies, not that there's a great evidence base, but this is what many of our patients ask about. I took this from the Scleroderma and Raynaud United Kingdom website. So antioxidants, vitamin C and E, are thought to have mild vasodilatory properties, as well as essential fatty acids. These drugs or alternative preparations increase endogenous prostaglandins, that is gammalenic acid, omega-3 fish oils, ginkgo biloba, and ginger. Many people, including those at the Meet the Professor session this morning, ask about the utility of statins. So Anna Abu Raya from Egypt published this study suggesting a beneficial effect of statins in these patients. But unfortunately, Robin Domsick's group from Pittsburgh was unable to demonstrate a beneficial effect of statins in this small clinical trial. A more innovative or advanced therapy is botulinum toxin or Botox injections as a local sympathectomy. In this case, it's mixed evidence. Some patients get benefit from the digital block, but the benefit is not sustained. More advanced therapy is the consideration of hyperbaric oxygen therapy. Dr. Huda Alfaris recently reported in a case report and review of the use of hyperbaric oxygen for the treatment of this particular patient's digital ulceration. And after 6 weeks of hyperbaric oxygen therapy, you can see that she had complete resolution of the digital ulceration and gangrene. So now I will move on to under-recognized but common considerations in systemic sclerosis. Dr. Omer was among the first to report the recognition of low bone density and osteoporosis in systemic sclerosis. In 2 studies, he demonstrated that systemic sclerosis confers an increased risk of low bone density and increased risk of fracture. He reported that the mean 10-year risk of fracture was 10% of all osteoporotic fractures and a 10-year risk of 4% for femoral neck fractures. These patients are susceptible to the traditional risk factors for low bone density, that is menopause, family history, steroid use, smoking, ethnicity, physical activity, etc. But also, there are scleroderma-specific risk factors that confer an increased risk of osteoporosis, including extent of skin involvement, low body mass, internal organ involvement, calcinosis, and malabsorption. Nabil Hakami did a nice retrospective cohort study looking at the risk of venous thromboembolism in systemic sclerosis. He demonstrated that the presence of interstitial lung disease, pulmonary arterial hypertension, pulmonary vascular disease, SCL70 autoantibodies, and anticardiolipin antibodies are all risk factors for venous thromboembolism. And in a subgroup analysis, he found that systemic sclerosis patients with interstitial lung disease more frequently experience DVT with a relative risk of 2.85. So this confers a clinically relevant pearl. If you have a patient with scleroderma-associated ILD that presents to your office with acute worsening of their shortness of breath, consider investigating them for a pulmonary embolism that is now resultant from the DVT due to their immobility. Acute worsening of shortness of breath does not always mean worsening of the ILD. Badr al-Mebdi reported a nice study looking at the prevalence of peripheral neuropathy in people with systemic sclerosis. He found that peripheral neuropathy in people with systemic sclerosis can occur for 2 main reasons. The most common is compression neuropathy. People can have compression of peripheral nerves due to cutaneous edema, cutaneous fibrosis, and most commonly, calcinosis. That is the calcinotic lesions compressing the nerves. In another group of patients, patients can develop a symmetrical peripheral neuropathy, usually sensory in the lower extremities. With regards to the compression neuropathies, the most effective treatment is relievement of the compression, that is surgical removal of the calcinotic lesions. With regards to the lower extremity sensory neuropathies, he is reported on both immunosuppressive and non-immunosuppressive therapies. The most common immunosuppressive therapies are prednisone, cyclophosphamide, azathioprine, and IVIG. The most common non-immunosuppressive therapies are amitriptyline, pregabalin, gabapentin, and tricyclic antidepressants. So, in summary, I have presented for you the evolving landscape for systemic sclerosis as it relates to our changing understanding of the epidemiology for risk factors for disease susceptibility, as well as our thinking around preclinical and early disease. I've tried to highlight for you important concepts beyond fibrosis, that is, management strategies for vasculopathy, and highlighted for you common yet under-recognized manifestations of systemic sclerosis. Before I conclude, I'd like to take this opportunity to make a personal note or personal reflection. Over the years, I have had the great honor of working with many excellent Saudi rheumatologists. In this slide, I highlight for you the people that I've worked most closely with, but there are many more Saudi rheumatologists in this room that I have gotten to know over the years during your time in Toronto. I would like to express a sincere thank you because it has been a great honor and probably one of the most meaningful aspects of my career to have worked with you. And now that I'm here in Saudi Arabia, I am thrilled to see how far all of your careers have come. And I'm most humbled to call you my friends. Thank you for your attention.
Thank you very much, Sendo, for this amazing presentation. We really admired the slides and the beautiful presentation of our colleagues' work. I really admire your presentation. So we're going to open the session for discussion, and we'll take questions. So can we have the mic over there, please? Mike. يا جماعة هنا. هنا دكتور.
Thank you very much. So my question is to Dr. Yasser. So I do a twice-a-month clinic with respirologists, and we see a lot of sarcoidosis cases. So they told me recently, over the last maybe 2 months, that they have a new recommendation from their societies that the dose of oral steroids to be used for pulmonary sarcoidosis is not to go beyond 20 milligrams. I want your comment on that because I think the using of steroids has been, one of the unmet needs that we see a lot of patients who have complications from use of steroid. The question also, the second question is, when they have extra pulmonary manifestation like uveitis or they have arthritis, it's easy to convince my respirology colleague to put the patient on a DMARD, methotrexate or any other medication. But if they have only pulmonary manifestation, usually from the first, no, we're going to use an oral steroid, we'll see what's going to happen. Most people are going to go in remission, they don't need to use any other medication. If they have the second flare, maybe I'll be able to convince them. But if they have the third flare, which sometimes I see use it, like they use it for a long time. They can use it for like 8 and 12 and maybe beyond that. I'll be able to convince them. What's your advice for me to convince them the early introduction of these conventional DMARD or eventually maybe some of the biologic therapy to prevent steroid complication?
Thank you for this comment. Actually, I didn't come across guidelines or recent recommendation. But regarding the second question, actually, if the patient did not respond and he got like a recurrent flare and recurrent flares, the data from what I get even my presentation, I didn't come across a solid evidence that we should go into one option in favor more than the other options. But still, like anti-TNF, still like it's the standard recommendation, and it's like several data point toward the use of anti-TNF in a patient with pulmonary and extrapulmonary sarcoidosis. We are waiting for the other data from like abatacept, which look like a promising data about the safety in the pulmonary sarcoid in general. Tofacitinib also is a promising medication. So, see.
Next question.
Thank you very much. It was quite a nice, refreshing recipe for the morning. My question again for Dr. Yasser Bawazir, in response to your last question that came on your slide, who should be caring for those people? The disease is quite rare, and I think many of us, even after maybe decades of practice with more than like a handful number of cases, but it's a concerning who should be the caring, considering that extra pulmonary manifestation is way much less common than pulmonary one, and in particular the MSK manifestation. Most of the time, the pulmonologists, they would very much hand over the care for us, and the argument is they don't have experience with all second, third, fourth line that we use. And that's not different from also our colleagues in neurology, and we're all in neuro involvement with rheumatic disease eventually landed up seeing us, and probably would be the leading or the primary caring for that. Of course, the MDT would be the best, but since it's not implemented everywhere, and I guess we have to really assume that we be the primary responsible for those people to prove it otherwise. I don't know what is the thought of the rest of the thing. That's one comment. The other comment for Dr. Sindhu, the paper that you presented about hyperbaric oxygen, since we have a unit that particular patient, was he on other interventions? Were he in other medications? Or what the sole thing was hyperbaric oxygen, just to see if there's any sort of, to see it was the major sort of influencing thing on healing, that nice healing of the ulcer. Thank you.
Yeah. Thank you, Dr. Ahmed, for this comment. Actually, I put this question just to address who should involve. It should be a multidisciplinary. I know most of us here in the podium, we are not interested to treat all patients with sarcoidosis, rare disease, and usually we don't see too many cases. But I think our role is just to monitor and observe patient on DMARDs as well as biological treatment, because we are more familiar with this medication than other colleagues from other specialty. Thank you.
So thank you for your question relating to hyperbaric oxygen therapy. So the evidence to support its use is modest at best. We generally learn from the diabetes experience. There's a more robust evidence base to suggest the use of hyperbaric oxygen for diabetic-induced ulcers. So at this point in time, we generally reserve hyperbaric oxygen therapy for refractory ulcers. We normally start with medical management first. So in the case of the patient that Dr. Alfaris published on, this patient was on combination vasodilator therapy, calcium channel blockers, nitrates, as well as complementary low-dose aspirin. But despite those therapies, was still progressing. So that is why we added hyperbaric oxygen, and thankfully was able to heal the ulcer.
تفضلي دكتورة.
Thank you very much for all speakers. Great session. My question for Prof. Al-Amir, what's your experience with the use of belimumab in Sjögren patient? When you're going to introduce it, and what the result you saw?
Thank you for your question. So basically, belimumab have shown positive results in both extraglandular manifestations and patient-reported outcomes in a phase 2 clinical trial. And then they did another study looking at belimumab and rituximab combined, which showed no difference between belimumab with or without rituximab. Now, in the patients that I have treated with belimumab, they are actually limited. So I have treated 4 patients with belimumab, mainly for Zika symptoms, not for extraglandular. And 2 of them, especially one of them was a super responder. So she was having significant Zika symptoms despite being on full dose of pilocarpine, and within 6 to 8 weeks of starting belimumab, her dryness improved dramatically. The other one took some more time to improve, and I have one patient who had not responded at all during 6 months, and basically this patient had Sjogren's syndrome for like more than 20 years. So I think that the inadequacy of response in some of these patients are related to the complete destruction of the lacrimal or salivary gland, which will not really respond to immunosuppressive agents. So we're really excited to see some patients responding to belimumab because you have one additional option to add. In view of rituximab, just to complete the whole picture, you might see some response in patients with secondary Sjogren, for example, to RA, if you give them rituximab to control their RA. Some of them report improvement in these Zika symptoms, but in general, on a group level, rituximab does not have a significant effect on a patient-reported outcomes. So it is an option.
تفضلي.
Thank you. My question to Prof. Sandua about the role of anti-estrogen therapy. Is there any evidence of that anti-estrogen therapy can help in preventing progression of the disease, especially since the prevalence is more higher in female rather than male? This is number one. And number two, about the role, is there any role for steroid therapy in patients with severe renoid due to systemic sclerosis complicating with gangrene and something like this when there is no response to the vasodilators and aspirin? Thank you.
So the first question was if there is any option to block the estrogen. And the second question is about the use of steroids. Is there any role for steroids in patients with refractory?
Thank you. So the issue of hormonal therapy in systemic sclerosis is very uncertain. There was a time where people were afraid to use hormone replacement therapy in these patients due to increased risk of disease flare or thrombotic disease. But really that was extended from the concerns from lupus. And so there is less evidence to be concerned about that. And so now if you look at the ACR reproductive health guidelines, it does suggest using hormone therapy for reproductive issues. But as for using the hormone therapy to prevent the development of systemic sclerosis or treatment of systemic sclerosis, that has not been studied to the best of my knowledge. As for steroid therapy in refractory disease, we're quite concerned about the use of glucocorticoids due to the risk of increasing the risk of scleroderma renal crisis. So in generally, we try to avoid glucocorticoid use for any indication. That being said, if someone has significant inflammatory myositis, particularly if they're critically ill, or if a patient has rapidly progressive ILD, which I'll speak about shortly, then we would consider high-dose glucocorticoids. But that is a very important decision because we will essentially be trading one organ for another, meaning to save the lungs or to stop the myositis because they can't breathe or they're being intubated, we are willing to sacrifice the kidneys.
Okay, we're going to take, for the sake of time, we're going to take the last question.
Thanks for the excellent session. My question about the reliability of the nail fold capillaroscopy. In absence of the autoantibodies with positive Raynaud's and early puffy hands, how reliable is and when we can start the second-line medication, cytotoxic medication for that?
Sure. So thank you for your question about the role of capillaroscopy and antibodies. So when we think about the pre-scleroderma, the VDOS criteria, if a patient has Raynaud phenomenon, ANA, and puffy fingers, and the presence of abnormal nail fold capillaries, but the absence of scleroderma-specific antibodies, we still would classify them as VDOS. Now, whether these people need to be treated or not is somewhat questionable, not supported by evidence, but some people would consider treatment with, say, something like Plaquenil, just to treat the puffy fingers. But most centers would not initiate biologic therapy or mycophenolate at that point in time. But the study in terms of the people with VDOS or pre-scleroderma, how many will go on to develop full-blown disease? There's a higher proportion if you have the scleroderma-specific antibodies and less likely a progression in the absence of the scleroderma-specific antibodies.
If you are open-handed to start second line, which would be your option for such cases?
Well, if I had to start something second line, I think most commonly I would start with mycophenolate because that is the first-line treatment for systemic sclerosis. But if they had inflammatory arthritis that's rheumatoid factor positive or CCP positive or had erosions on baseline X-ray, then I would consider tocilizumab or rituximab.
Actually, I was planning to conclude the session, but I was forced by my colleague, the co-chairperson, to have one more question.
Hi, thank you for the excellent and comprehensive talk. I just want to ask about the VDOS. So what's the implementation of VDOS in clinical practice? So in my opinion, it's the vascular stage of the disease when it's very early before it's progressed to a fibrosis. So do you encourage aggressive immune suppression at that stage or just wait and watch the patient at that stage?
Well, that's a very provocative question. So the traditional answer is we just treat what the patient has, right? Many of these people will develop Raynaud phenomenon in their 20s or as a teenager in their 20s. So we would treat the Raynaud phenomenon usually with calcium channel blockers. Yeah. But in this evolving landscape of trying to treat preclinical disease, if we look at lupus, the SMILE study, I think, looked at Plaquenil early. I think there's another study from the US looking at rituximab, so very aggressive immunosuppressive therapy early. So we are not there yet in the scleroderma world, but I think you can expect in the next 10 years, people will be talking about very aggressive therapy, perhaps even something like CAR T therapy to prevent the more sinister fibrotic manifestations.
Thank you.
With that, I would like to thank all the speakers for this entertaining session. And Hanan?
Many thanks for all chairperson speakers for the excellent session. Dr. Hiba Al-Hajri. دكتور أوس أبو عبات
بروف محمد عمير. دكتور ياسر باوزير. بروف سن. Prof. Sandur.
السلام عليكم ورحمة الله وبركاته. I would like to welcome you now to Eli Lilly Satellite Symposium. Can we have the first slides? First of all, I would like to thank Eli Lilly for their contribution in our conference. And this symposium will be around 25 minutes. ما يتحرك السلايدات. Yep. Okay, so this is my disclosure. Few disclaimers and housekeeping issue about this symposium, that the program is sponsored by Eli Lilly, and the speakers are presenting on behalf of Eli Lilly and Company. All information obtained from Eli Lilly Company is strictly confidential and shall not be disclosed to be used for any purpose beyond furnishing service to Eli Lilly Company. The data included in this presentation are from scientific peer-reviewed publication and from speakers' own clinical practice. All material is intended to be scientific discussion and medical education purpose. Housekeeping rules, please don't take any photo from the slides during the presentation, and don't post anything in the social media. This is a short video about discussion guidance. Yeah, can you put it on? Okay. الصوت. الصوت. ما في صوت؟ Okay, if there is. Okay, just because of the time, maybe I will bypass it. Okay, next slide. So this satellite symposium is mainly about real-world data from rheumatoid arthritis as well as psoriatic arthritis. We'll go through what is real-world data and how do the concept and the study definition differ from randomized control trials, and what question can real-world evidence answer about psoriasis. How can real-world evidence be applied to help in differentiating between biological therapies? And this is the main objectives from this symposium. So what is real-world evidence? All of you know that real-world evidence is an information that we get it from practice or from sources other than clinical trials. And it reflects everyday life and collected all the time. It could be a clinical, real-out data, could be economics, could be even patient outcome report data. And it can be used in the healthcare to answer specific questions that cannot be addressed by other ways, by the usual clinical trials. And the famous example of that, the Birmingham heart study for the risk factors, as well as the risk factor for breast cancer from the nurses' health care study. يا هذا بس أنا الصوت في برضه. Okay, so what is the sources for these data? Usually, any source other than the clinical trials, like could be retrospective study, cohort, observational study, but the best source for the real-world data is from the registry. And there is a lot of registry reflect. An example of the registry, the core EVIAS registry, which is previously called Corona Registry for Psoriasis, where they have more than 12,000 patients of psoriasis. In this registry, sometimes possible selection bias, because sometimes there is aim for introducing patient in the registry, studying specific thing. And the other example is the SOLAR registry, which include patients from 16 countries, the majority of the patients from the North America. Other source, like claims. The claims is a large established patient cohort with a long follow-up period. And this is millions of patients you can find in the data. And these patients is mainly medication, side effect, and diagnosis. You don't have much of information in this claim study. And so it's a limited information. Other source like electronic health record, EPIC, electronic medical assistant example of this dermatology modernizing medicine. It's a large established patient cohort with a long follow-up period, transforming the data for research purposes and may require sophisticated, actually, statistical tools. So let us start with the first speaker. Our first speaker is Dr. Ibrahim Al-Hamoud. He is known for maybe all of you. He's a consultant rheumatologist from King Fahd Medical City, and he is chairman of fellowship program, rheumatology fellowship. He is going to talk about navigating real-world evidence effectiveness beyond clinical trials in psoriatic arthritis. So welcome, Dr. Al-Hamoud.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank Lily for inviting me to talk on their behalf. I'm going to talk about navigating real-world evidence effectiveness beyond the clinical trial in psoriatic arthritis. This is my disclosures. Now, the head-to-head trial in PSA, we have the first one in 2019. It was the ixekizumab versus adalimumab, where they reported both ACR50 and PASI 100, and it was superior to adalimumab. So at that time, we got the first H2H trial in PSA, which explored that the efficacy of IL-17 as superior agents when we are treating in a holistic approach patient with PSA. In 2020, there was a EXCEED trial which tests secukinumab versus adalimumab, and they look for ACR20, and there was no superiority versus adalimumab. In 2021, there was looking for upadacitinib versus adalimumab in select PSA, and they looked for ACR20 at week 12, and it was not superior to adalimumab when we look to this study. So it's very important before going further, when we read the study, we have to look to the endpoints where they're looking to the joint manifestations or joint as well as the skin manifestation. And ixekizumab spirit head-to-head, when we look to the DAPSA remission, as compared to the other agents, adalimumab, as you see the superiority very clear, and particularly when we look to the MDA, which is a very tough to be achieved, it was achieved in 48% as compared to 35% in adalimumab. Now, this is the first real-world evidence that looks to what we call PROs, which is extremely important in rheumatological disorder. We should look for the effectiveness as well as the patient-reported outcome. And this study is an observational study. It's a multi-center trial, and several countries has been participated in this trial. More than 1,000 of patients with PSA, and they look to the different treatment that's prescribed usually in patients with PSA. This is the eligibility criteria as usual, patient, adult individuals with PSA and the prescribed or the prescribed treatment according to their treating rheumatologist. They look for IL-17, TNF inhibitors, IL-12, 23 inhibitors, as well as IL-23. Also, they look to the JAK inhibitor. And the primary endpoint was at 3 months, but they are planning up to 24 months. So we have now the results for the first 3 months. And very important for all of us, they looked and they compare between the DAPSA as well as the clinical DAPSA when you remove CRB. And this is very important for anyone who have a difficulty in the labs or who are working in the periphery where there is no availability of the CRB. And as you all know, CRB, it carries 1 point. So whenever you look to the DAPSA and clinical DAPSA, what you need is just to remove 1 point, and this is reflecting the clinical DAPSA. And I'm not sure it's mentioned here or no, they found that the DAPSA is doing similar to the clinical DAPSA, which is we all know because the CRB is elevated in less than 50% of our patients. Now this is the demographic for ProSpirit, and the important things that patients who were given TALS or exekizumab have very well established disease, more than 9 years, and more than almost 70% of the patient has been exposed or failed the previous biological DMARD or previous targeted synthetic DMARD. And then when we look to the clinical DAPSA remission or low disease activity at week 24, when we look to the TNF versus secukinumab, TNF has been achieved in 43%, 46% of patients with secukinumab. And it's 44% in a patient who were receiving TALS, 39% in secukinumab 300 milligram, in IL-12, IL-12/23 inhibitors, Stelara 36, and IL-12/23 inhibitors, it is 32. This is at 3 months reported outcomes. And again, when we look to the MDA, LDA, or the HDA, it was being reported in different treatment lines. What's important to us here is exekizumab. At 44% of patients, they achieved remission, and almost 43% of patients achieved the MDA. The early improvement in the joint swelling and tenderness has been reported, and as you see here, the highest one was with JAK inhibitor -3.1, and then TALS -2.7, which is almost similar to the anti-TNF -2.7, when we are looking for the swollen joint count. When we look to the tender joint count, it has been reduced, as you see, in -4.3 in exekizumab, -4.3 in anti-TNF, and -5.1 in JAK inhibitors. The improvement in skin psoriasis, when we look to the body surface area, more than 3% at the baseline, who achieved body surface area less than 3% at week 24, has been achieved in 58% in patients who were given exekizumab, secukinumab 50%, and as you see, the other line of therapy, JAK inhibitor 53%, IL-23 45%. And this is the safety or the side effect. The major side effect in patients who were given exekizumab was injection site reaction. And that's because of the presence of the citrate. And we have to mention that the citrate-free exekizumab is available in our country since the last few months, since I think September 2024. The major cause for the injection site reaction is citrate, and now we have citrate-free exekizumab. So exekizumab demonstrates an early response as early as month 3 across the joint and skin in real-world data, and demonstrates joint efficacy even in bio-experienced patients across different joint outcomes, whether we are looking for the swollen or tender joint, and it has the highest response rate at 3 months for the skin involvement among all the available treatment for psoriatic arthritis and psoriasis. And now we'll move toward the other disease, which is the latest real world in RA, which will be presented by Dr. Naif Al-Ghanem, who's a consultant in King Saud Medical City. Allah yakfir.
Guys, good morning. So I'll talk to you today about baricitinib and rheumatoid arthritis. Okay. So this is my disclosure. So I'll start with talking about the PERFECT RA study. This is a 48 weeks multi-center randomized open label study. The objective of this study is to examine the efficacy of baricitinib versus TNF inhibitors. First, they look at the non-inferiority of baricitinib versus TNF inhibitor, and then they look at the superiority of the treatment. It included 199 patients. All the patients had a disease duration of less than 5 years, and all the patients failed conventional DMARDs. So what they did, after the patient failed conventional DMARD, they were randomized to use either baricitinib or TNF inhibitors. If the patient achieved improvement at 3 months and remission at 6 months without toxicity, they continue the treatment and they try to lower the dose. If they don't achieve the treatment, they switch baricitinib group to TNF inhibitor and TNF inhibitors to baricitinib. The patients were assessed at 0, 12, 24, 36, and 48 weeks. The non-inferiority and superiority of the medication used ACR 50 to assess these objectives. So as you can see, as per protocol analysis as intention to treat analysis, first, baricitinib was non-inferior to TNF inhibitor as the inferior or the lower bound of the confidence interval does not cross the non-inferior margin. Second, baricitinib was superior to TNF inhibitors as the lower bound of confidence interval does not cross the 0 or no effect line. The delta difference was about 22%, so the ACR 50 response with baricitinib was 42%, and the ACR 50 response in TNF inhibitor was only 20%. Baricitinib also helped to improve the symptoms rapidly. As you can see in the two diagrams, the maximum efficacy of baricitinib was achieved within 12 weeks, while baricitinib needed at least 36, while TNF inhibitor needed at least 36 weeks to achieve the maximum efficacy. So we can say that baricitinib patient responded very fast to treatment. The retention rate was also higher with baricitinib. There is about 10% difference between TNF inhibitor and baricitinib after 1 year of treatment. When we look at the patient-reported outcome, the well-being of the patients, pain assessment, physician global assessment, and functional disability was better with baricitinib versus TNF inhibitor group. Moving to another study, the Barebone study, baricitinib helped to improve DAS28 CRP, DAS28 ESR, patient pain, visual analog assessment, and physician global assessment. In this study, they looked at the efficacy of baricitinib in decreasing the bone erosions. What they use a high-resolution CT scan or quantitative CT scan to look at the bone erosions. And it's surprising that baricitinib did not only prevent the erosion, but also promote the healing of the bone. As you can see, that the erosion at baseline, the size was big, and after 52 weeks of treatment, there was improvement of the erosions, and it started to fill with the new bone formation. This is one of the few studies that looked at this issue, and this could be the first treatment that showed improvement of bone erosions in patients with rheumatoid arthritis. In this slide, you can see that baricitinib helped to decrease the dose of steroid. At baseline, the dose of steroid was 5 milligram, and after 12 months of treatment, it decreased to 1.2 milligram. And the efficacy was seen in both biologic DMARD naive and biologic DMARD inadequate response. The BeReal study examined the retention rate of baricitinib versus TNF inhibitors and baricitinib versus other mechanisms of action. And baricitinib retention rate was again higher compared with TNF inhibitor and other mechanisms of action. And this can be seen in biologic naive patient, biologic experienced patient with less than 65 years old and those who are 65 years or older. Moving to the safety of baricitinib, from the rabbit registry, which is an RA registry in Germany, they examined the safety of all the medications in rheumatoid arthritis. And when you look at the major adverse cardiovascular events, there was no difference between JAK inhibitor, TNF inhibitor, and conventional DMARDs. This result was also seen in high-risk patients, and this is different what we have seen with the oral surveillance study. We showed higher MACE with tofacitinib treatment. So in summary, baricitinib had higher remission rate versus TNF inhibitor. It has higher retention rate versus TNF inhibitor. It improved bone strength, prevent new erosion, and also promote the healing of bone erosions. Finally, there is flexibility with the dosing of baricitinib. We have 2 doses, 4 and 2 milligram, and baricitinib can be used as a monotherapy without methotrexate in patients with rheumatoid arthritis. Thank you.
Thank you, Dr. Naif. Thank you, Dr. Ibrahim. It's open for question. So any questions from the audience? So I can ask Dr. Ibrahim, regarding this real-world evidence in psoriasis, how it differ from the clinical practice? Did it add something new?
Thank you very much. Actually, now we need real-world data for each single disease. The advantage of real-world data, it's including all the type of patients with all comorbidities. So it's really different from the RCTs. And as you might see now in the future, everyone is pushing for the RDW because it's reflecting our real practice. So yes, the answer is yes. It's including many patients with comorbidities.
Those with comorbidity more in real-world data. Despite of that, there is a good outcome. And regarding the safety, any different?
Yes. When you look to the real-world data, in general, they included, for example, for IL-17, they included inflammatory bowel disease, which is usually excluded by RCTs. And we come in conclusion that it looks like if you have IBD who is in remission, you can use IL-17. This is a hint from RDW. You cannot find it in the RCT, for example.
Yes, thank you. Any more question for? No question, Dr. Naif, regarding the real-world data about, you specified Bari in this one compared to the other modality. And when we saw the figure, though it's numerically higher, isn't it? But what about statistically? Is it higher than the other modality?
Yes, in the perfect RA study, it was statistically significant. So the superiority of baricitinib versus TNF inhibitor was statistically significant. There was a 22% difference between baricitinib and TNF inhibitor, which I think is significant.
And in this, usually the controlled study, they use a dose initially of 4 milligram, where we have more side effect. And here in the real-world data, is it 4 milligram or 2 milligram?
Yes. Once the patients achieve remission, whether TNF inhibitor or baricitinib, the physician can lower the dose of baricitinib or space the TNF inhibitor. So in both treatments, they were allowed to do that.
Yeah, great. And regarding, one question here. Yes.
Thank you. My question regarding subclinical synovitis. Do you follow patients for subclinical synovitis, and will you change the treatment based on that? Subclinical synovitis, ultrasound finding.
Synovitis?
Yes. If you find subclinical synovitis with the medication, would you change the treatment even if the score is good?
Ultrasound. Well, personally, I don't treat any finding if the patient doesn't complain. So subclinical arthritis with a high CRB, ESR, ultrasound finding, particularly after the publication where they show clearly the mismatch between the ultrasound finding and the clinical finding. Again, I was stressing the point, synovitis that's detected by ultrasound, grade 1, please don't treat unless the patient has clinical features.
Even if Doppler positive? Doppler positive synovitis.
Okay. الصوت مو واضح بس because of the time finished we have to start the other session. So you can ask Dr. Hamoud, he can answer you later on. Thank you all for your presence. Thank you all.
IT, yeah, thank you. So, dear President, should we start? Should we start? نبدأ? Okay. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Blessed Friday, ladies and gentlemen. As a member of the Scientific Committee for the 11th SSRC, I would like to welcome you all to the conference, and I would like to congratulate the Saudi Society for Rheumatology for a very successful meeting, and looking forward to attend the 20th Saudi Society for Rheumatology conference in the near future, inshallah. It's a privilege and an honor to share and chair actually this session entitled Scleroderma Lung Disease with my colleague, Dr. Mahal Mckenzie, who is a consultant rheumatologist and myositis specialist at the Security Forces Hospital in Riyadh. So for this session, we will have two well-known speakers in this field. I will introduce the first speaker. So it is my absolute privilege to introduce someone who has had a profound impact, not only on my journey, but many of us. While her credentials and contributions to the field of rheumatology are well known to all of us, I would like to take a moment to introduce her in a different light. So she's not just a brilliant mind in medicine. In fact, she is a mentor in the truest sense of word. She leads with kindness, listens with patience, and gives with generosity, not only her time, but her wisdom, her encouragement, and belief in those she guides. She has shown many of us that mentorship is not just a guidance, it's actually lifting those who are like her mentees, encouraging them, and celebrating their success, and always reminding them that they are capable of more than they think. It was an honor to learn from her, and it's an honor to introduce her today. So ladies and gentlemen, please join me to welcome on the stage again, Sindhu Johnson.
Thank you, Dr. Hafiz, for that really beautiful introduction. I hope this next lecture will live up to that introduction. So again, thank you to the Saudi Society of Rheumatology and Madam President for the opportunity to share with you the American College of Rheumatology, American College of Chest Physicians, CHEST, guidelines for the screening, monitoring, and treatment of interstitial lung disease in the systemic autoimmune rheumatic diseases. So I've already shared my disclosures, but most importantly is that I do have relevant conflicts of interest for this guideline because I was a clinical trialist on the data that was used to inform this guideline, most specifically on nintedanib and tocilizumab. And so I gave up all of these financial conflicts of interest 1 year prior to the conduct of these guidelines. The guidelines were published in August of 2024, and I will continue to give up all these financial conflicts of interest for at least 1 year after the publication date. So the objectives of this session are to explain the ACR guidelines, and then more importantly, to share with you the evidence-based clinical practice guidelines who are intended for clinicians who care for people with the systemic autoimmune rheumatic diseases that are at increased risk for interstitial lung disease. So let's start with clinical pearl number 1. You may notice that I keep referring to the SARD diseases, the systemic autoimmune rheumatic diseases. In our training, we are more familiar with the term connective tissue disease, or CTD, but this is sort of an older nomenclature, as CTD can also include things like Ehlers-Danlos syndrome. But we realize that that's not really the purview of a rheumatologist. So now you will increasingly see the term SARD to refer to our seropositive diseases. Clinical practice guidelines are among the most important documents that a professional organization can develop. The primary objective of a clinical practice guideline is to help guide healthcare professionals in the care of our patients. However, there are a number of secondary objectives of a guideline. A secondary objective is to reduce geographic practice variation. A patient should not expect to receive different care depending on where they live. Equally important is that a clinical practice guideline can be used as an advocacy document. A clinical practice guideline might recommend a treatment or some sort of testing that is not available in your jurisdiction. And so once a guideline is published, you can use the clinical practice guidelines to advocate to the government or to the payer to have coverage for whatever is being recommended. And finally, a clinical practice guideline can increase awareness. And this was part of the motivation for the American College of Rheumatology to team up with the American College of Chest Physicians to develop a guideline to promote awareness of interstitial lung disease in rheumatologic conditions. Now, a very important caveat is that classification criteria are often meant to be international in scope, but clinical practice guidelines are not international in scope. They are regional in scope. So this guideline that I'm presenting to you is developed for Americans. Now, I'm a Canadian and I'm honored to have been asked to lead this group, but really this guideline is not even really for Canadians. If one wants to apply, now I share it with you so that you may decide whether you want to apply these guidelines in your practice or not, but if the Saudi Society of Rheumatology wants to consider application of these guidelines, one may consider a process that was used by Professors Omer and Al-Raiz in the development of the American College of Rheumatology guidelines for the management of rheumatoid arthritis for Saudi Arabia. So after hearing today's presentation, you may choose to the development process for the Saudi Arabian context. And why? Why do we say that clinical practice guidelines are regional in scope and not international in scope? The reason is that clinical practice guidelines are sensitive to patients' preferences and values, and that may be influenced by the culture of the region. Furthermore, the guidelines may be influenced by cost and access to care. Now, if you have a clinical question, and there are 5 randomized trials looking at the efficacy and safety of that drug, one doesn't really need a guideline. It's pretty obvious what the answer is. But the real utility of a clinical practice guideline is when there is an absence of evidence or a paucity of quality evidence, because that's where you want to know what do the experts and patients think. So a few methodologic considerations. You heard Dr. Abawabat and a few others speak about practice guidelines, and there are different methodologies to develop the guideline. The American College of Rheumatology prefers the GRADE approach, grading of recommendations, assessment, development, evaluation. In this approach, all forms of evidence are considered eligible. That is published evidence as well as expert opinion or expert experience. This evidence must be graded as high, moderate, low, or very low in its certainty. So, randomized trial-generated evidence is generally considered moderate to high certainty, whereas observational studies are thought to have low or very low certainty. These studies may be further downgraded due to limitations in the study design, inconsistency of the results, indirectness of evidence, imprecision, or publication bias. A final point that I'd like to make about rheumatology trials is that compared to other specialties, our clinical trials are very small. So this table summarizes 4 ILD clinical trials in rheumatology. And if you just look at the sample sizes, our clinical trials tend to run in the hundreds of patients. Now, in contrast, here's a summary of a few cardiology trials. And you can see that their sample sizes are in the thousands or tens of thousands of patients. And so this can affect the certainty around our estimate of treatment effect. A second issue affecting our clinical trials in the ILD space is that the primary outcome is almost always forced vital capacity. Now, this is a surrogate outcome that doctors value. However, a surrogate outcome is one step removed from what the patients and the US Food and Drug Administration care about. Patients and the FDA don't care about FVC. What they care about is what patients care about: living longer, how they feel, and how they function. And so the consequence is that even a well-designed scleroderma or a rheumatoid arthritis ILD clinical trial will be downgraded to low or very low certainty evidence because of the use of a surrogate outcome. So now let's move on to the guidelines themselves. Who should be screened? Well, these guidelines take a risk-based approach. We recognize that rheumatoid arthritis, systemic sclerosis, inflammatory myositis, mixed connective tissue disease, and Sjogren's disease all confer an increased risk of developing ILD compared to the general population. However, the risk of developing ILD and the risk of ILD progression can vary within each disease and between the diseases. So in the guideline document, we present a table of the published risk factors. So in this case, the risk factors for development or progression of ILD and systemic sclerosis include the presence of autoantibodies, diffuse subtype, male sex, Black race, early disease, and elevated acute phase reactants. So essentially, everybody with systemic sclerosis should be screened for ILD. Now, in the document, we also report other risk factors to help guide clinicians. It is not meant to say who must be screened. Your judgment is still required, but here is a summary of risk factors across the diseases who are increased risk for developing ILD. If you are uncertain whether you should screen or not screen, we'll then err on the side of caution and screen the patient. With regards to screening tests, 2 tests are recommended. The first is pulmonary function tests. That includes spirometry, lung volumes, and diffusion capacity. This is an important caveat because many of our respirology colleagues will just do office spirometry and not do lung volumes or diffusion capacity. So the recommendation for screening is full pulmonary function tests. The second test is a high-resolution CT thorax. So another clinical pearl is that many of our patients, when they develop acute onset shortness of breath, will present to an emergency department, and there they will get a CT angiogram looking for a PE. Now, a CT angiogram is performed at incomplete inspiration to maximize pulmonary artery enhancement, and this in turn can induce atelectasis that may obscure or mimic interstitial lung disease. And so as a consequence, CT angiogram studies are very inadequate to screen for interstitial lung disease. It should not be considered a screening test. So now let's look at monitoring tests. 3 tests are recommended. The first is pulmonary function tests, again with spirometry, lung volumes, and diffusion capacity. In patients with systemic sclerosis, it is suggested that we monitor every 3 to 6 months in the first year and then less frequently once stable. It is also recommended that these patients be monitored with ambulatory desaturation testing every 3 to 12 months. it is recognized that ambulatory desaturation testing is not within the scope of practice for our rheumatologist. This is something that our pulmonology, our respirology colleagues do. So once a patient is diagnosed with interstitial lung disease, it is recommended that we do shared care with our pulmonary colleagues, and this would be a test that falls within their domain. The third test is the second test is I already talked about the ambulatory desaturation testing. The third test is high-resolution CT thorax as needed. There are several tests that are conditionally recommended against for the screening. We recommend against the use of chest x-ray, 6-minute walk test distance, ambulatory desaturation testing, and bronchoscopy for the screening of ILD, and there's a strong recommendation against surgical lung biopsy. Now, these tests may be used to rule out other diseases, such as infection, sarcoidosis, lymphoma, or alveolar hemorrhage. Similarly, with the monitoring of interstitial lung disease, it is conditionally recommended against the use of chest x-ray, 6-minute walk test distance, and bronchoscopy. However, these tests may be used if a patient is unable to get a good oral seal on the pulmonary function test, or if you need to do bronchoscopy to rule out infection or alveolar hemorrhage. So now let's move on to first ILD therapy. Across the top, you'll see the 5 diseases: systemic sclerosis, myositis, mixed connective tissue disease, rheumatoid arthritis, and Sjogren's disease. You will then see a menu of options that are available to you. The menu of options are separated as preferred, that is, those that are expected to be most commonly prescribed, as well as additional therapies, those that may be used in certain situations. Now, there are some situations that might lead a provider to choose a different option within that menu of options. For example, comorbidities or extrapulmonary disease. So let's look at the first ILD treatment. Across all of the 5 rheumatic diseases, it is recommended to use mycophenolate for the treatment of the interstitial lung disease. However, for example, in the setting of rheumatoid arthritis, if someone also had active inflammatory polyarthritis, one may choose rituximab to manage both the ILD and the peripheral arthritis. There is a strong recommendation against the use of glucocorticoids in people with systemic sclerosis-associated ILD due to the concerns of inducing a scleroderma renal crisis, whereas there is a conditional recommendation for the use of glucocorticoids across the other 4 diseases. The next grouping of recommendations relates to those who have progression of their ILD after initiation of the first ILD treatment. For the purpose of the guideline, progression of ILD was defined using the INBUILD criteria, that is, a relative decline in FVC of at least 10% predicted, or a relative decline in FVC of 5 to 10% predicted, and worsening of respiratory symptoms, or an increased extent of fibrosis on high-resolution CT, or worsening of respiratory symptoms and an increased extent of fibrosis, all occurring within 24 months. In this situation, again, we have the 5 diseases and a menu of options where you could consider adding or switching a therapy. So, if mycophenolate was not the first ILD therapy and there is progression, there is a conditional recommendation of using mycophenolate to treat the progressive ILD. In the setting of systemic sclerosis, other therapeutic options would include rituximab, nintedanib, tocilizumab, or cyclophosphamide. For those with myositis-induced ILD, one can consider rituximab, nintedanib, or cyclophosphamide, and across the other diseases, similar therapeutic options. What might be new to some people is in systemic sclerosis, considering referral for autologous hematopoietic stem cell transplantation for consideration of treatment of progressive ILD. There is a strong recommendation against long-term glucocorticoids, again, in the systemic sclerosis patients due to risk of scleroderma renal crisis, and there is a conditional recommendation against long-term glucocorticoids in the other patient groups. And finally, there's a conditional recommendation for referral for lung transplantation evaluation at an experienced center. The 4th grouping of recommendations relates to an entity called rapidly progressive ILD. This is a new entity of our time and refers to a subpopulation of interstitial lung disease that is characterized by rapid progression going from no oxygen to a high oxygen requirement, rapidly progressing in the order of days to weeks without a documented alternative cause such as infection or heart failure. This is different than the traditional ILD, where the natural history is progression over months to years. In this, you are most likely to be asked to consult on such a patient in the intensive care unit setting when you are on service. These are the patients that had a rapid progression of their oxygen and need for high flow oxygen, are now intubated and ventilated, sometimes on pressors. In such a situation, the first step is to consider, is there a high suspicion for the anti-MDA5 antibody? We more typically see this in the people with inflammatory myositis, but rarely you can see this in the other rheumatic diseases. The reason why it's phrased as suspicion for the MDA5 antibody is because if you order the antibody, it may take 1 or 2 weeks before you get the result, and we can't afford to wait that long to make a therapeutic decision. You often need to make a therapeutic decision that day. So the conditional recommendation is that if you have a high suspicion for MDA5 antibody, then it's combination therapy with intravenous glucocorticoid therapies and 2 additional immunosuppressive therapies. So, the more traditional therapies that you may be familiar with are rituximab or cyclophosphamide or mycophenolate. However, what I can share with you is experts at the high volume centers in the United States prefer IVIG and calcineurin inhibitors, that is tacrolimus. And the reason is these intubated patients in the ICU are prone to sepsis. And if we treat them with rituximab or cyclophosphamide, it's very difficult to manage their sepsis and control the immunosuppression. Whereas the expert centers in the US feel that it's easier to control the immunosuppressive therapy if you use IVIG and tacrolimus. This is a situation where practice is changing in advance of the evidence. So in the manuscript, we provide this table that summarizes medication dosing and monitoring. I highlight this for you because for many rheumatologists, we did not learn how to dose and monitor tacrolimus during our training. And so in this table, we summarize the dosing at 0.075 milligrams per kilogram per day, as well as the monitoring of trough tacrolimus levels. Now, there are many more treatment options to consider for the management of ILD in our patients, but was beyond the scope of this guideline. But as a service to consumers of the guideline, we do provide a table summarizing additional considerations. The first grouping is integrative therapies, otherwise known as non-pharmacologic therapies. It is recommended or suggested that you consider about counseling your patient on exercise, that is aerobic exercise training. Consider palliative care for discussion of symptom treatment such as cough, pain, and air hunger, as well as end-of-life planning. Consideration of physiotherapy for chest physiotherapy, airway clearance, and incentive spirometry. Consider pulmonary rehabilitation for cardiopulmonary rehabilitation and resistance training, and to consider supplemental oxygen testing. There are also additional pharmacologic therapies that you may want to consider. These include gastroesophageal reflux management with proton pump inhibitors or H2 blockers, PJP prophylaxis with Septra, consideration of pro-motility agents with something like domperidone, and vaccination. We recommend consideration of the traditional vaccines, that is mumps, rubella, etc., but more importantly, the respiratory viruses, that is influenza, COVID-19, pneumococcus, and RSV. Now, I'll share with you that the American College of Rheumatology has other guidelines relating to vaccines. And so, in a patient who's on rituximab, it is recommended that when they get their annual flu vaccination, we continue the rituximab. But notice the footnote. Give influenza vaccination on schedule. Then delay any subsequent rituximab dosing for at least 2 weeks after the influenza vaccination if disease activity allows. The American College of Rheumatology also provides guidance on COVID vaccination. For those receiving cyclophosphamide, it is suggested to time the cyclophosphamide administration so that it'll occur 1 week after each vaccine dose when feasible. With regards to our other immunosuppressive agents, notably mycophenolate, it is recommended to withhold the mycophenolate for 1 to 2 weeks as disease activity allows after each COVID-19 vaccination. The reason being is that we know that rituximab and mycophenolate reduce the immunogenicity of our vaccines. So if a patient has stable disease, it is preferred to withhold or delay the treatment so that we can maximize immunogenicity of the vaccine. So in summary, these guidelines provide a risk-based approach to the screening and monitoring of interstitial lung disease in people with the systemic autoimmune rheumatic diseases. These guidelines provide a range of treatment options, that is a menu of options that are based on the best published evidence, expert experience, as well as patient preferences and values. Now, if as an ACR member, you have free access to the papers. If you go to the ACR website, rheumatology.org, and you go to the section called Clinical Practice, Clinical Tools and Guidelines, you will find all the ILD manuscripts listed there. Similarly, for those of you who like handheld apps, the ACR makes available a free app that you can have on your mobile device, or it's free to ACR members, and that's where you can find both classification criteria as well as all of the ACR guidelines. This is what your membership fees pay for. I'd like to express a thank you to all the members of the guideline development team, but most importantly, I am proud to say that this guideline had the largest patient panel of any guideline in rheumatology across all of our organizations worldwide. And so these guidelines are very informed by patients' values and preferences. Thank you for your attention.
Thank you, Prof. Johnson, for the insightful and informative talk. Moving on, it's my pleasure to introduce our next speaker, Dr. Khalid Abaidallah. Dr. Khalid Abaidallah is a consultant of internal medicine and pulmonary medicine, and he will be at Prince Sultan Military Medical City. He will be discussing a crucial topic for most of us, which is pulmonary hypertension and systemic sclerosis. Welcome, Dr. Khalid. Floor is yours.
Bismillah wa salatu wa salam ala Rasulillah. Thank you, Dr. Amaha, for the kind introduction. I'm really excited to be here today, and I appreciate the warm welcome. I would like to also to thank the organizing committee for inviting me to participate in this informative, excellent conference. So for the next 15 minutes or so, I'm going to talk about pulmonary hypertension. So I have nothing to disclose. So my outline today is I would like to go over some of the definitions of pulmonary hypertension, how we diagnose the disease and how we treat it, and what's the impact of pulmonary hypertension. And I would like also to focus this on scleroderma, so we will know the similarity but also the difference of this form of pulmonary hypertension and other forms of pulmonary hypertension. So to define pulmonary hypertension by itself, it's not a disease. It's a hemodynamic definition defined as a mean pulmonary artery pressure more than 20 millimeter mercury measured by right heart cath. So this sentence has two significant values. Number one, in order to diagnose a patient with pulmonary hypertension, you need to get a right heart cath. Number two, the cutoff threshold for mean pulmonary artery pressure has been lowered from 25 in the previous guidelines to 20 millimeter mercury in the latest 2022 ESC-ERS guidelines. These hemodynamic states can be present with so many diseases, such as cardiac, lung, hematology, renal, liver, connective tissue disease, etc. And unfortunately, when any one of these conditions, pulmonary hypertension present, usually they had a much, much worse outcome. For example, if you have two patients with interstitial lung disease, they have both the lung function numbers. The one with pulmonary hypertension and the other one without PH, the one with pulmonary hypertension usually do worse and have a higher mortality. What is pulmonary hypertension and what do we mean by pulmonary arterial hypertension? As I said, pulmonary hypertension is to have a mean pulmonary pressure of more than 20, but this is not very specific. When we mention a pulmonary arterial hypertension, we are mentioning that the heart is normal, the left ventricle is normal, and the problem is in the pre-capillary arteriole components. So pulmonary arterial hypertension has a pre-capillary pH definition. So you will have a mean pulmonary artery pressure of more than 20 millimeter mercury, pulmonary artery wedge pressure of 15 millimeter mercury or less, and a pulmonary vascular resistance of more than 2 Woods units. Again, the cutoff threshold for the pulmonary vascular resistance has been changed from 3 in the previous guidelines to 2 in the most recent one. Pulmonary hypertension is a chronic, progressive, usually fatal disease. And when you get the hemodynamics number that was being done by the right heart cath, it is really important when you interpret these numbers, you should look at the whole clinical context of the patient in order to get to the right diagnosis. Precapillary pulmonary hypertension can be seen in other forms of PH, such as group 1, group 3, group 4, and group 5 pulmonary hypertension. So going to scleroderma and why this is very important. This is an old study that was conducted in 2013. Remember, at that time, the definition of pulmonary hypertension was defined as a mean pulmonary artery pressure more than 25. When they looked at two groups, the one who had a borderline pulmonary hypertension with mean pulmonary artery pressure of 21 to 24, and those with normal pulmonary pressure of 20 or less. If you can see in the gray line in the graph, those patients with borderline PH, when they follow them in the next 5 years, they have a 4-fold increase risk in developing and progressing to pulmonary hypertension. So lowering the threshold or the definition of pulmonary hypertension seems to capture a clinically relevant group, an important group for us to consider, especially in patients with scleroderma. So this slide showed you the most updated classification as per the guidelines of the SSRSA. In the past, we used to say primary and secondary pulmonary hypertension. And this is an obsolete language nowadays, which has no meaning whatsoever in the current pulmonary hypertension fields. We divide pulmonary hypertension into 5 different groups. Each group has its own specific pathophysiology, mechanism, and treatment strategy. And you cannot mix the treatment of group 1 with group 2 with group 4, or even group 3 with group 5. You cannot do that. Because if you do so, you increase the mortality for those patients. So we have group 1, which is pulmonary arterial hypertension, and I will try to focus today on associated with connective tissue disease. So why is scleroderma challenging? It is challenging, and I will explain that in the next slide, because it's fairly common, and systemic sclerosis can present in many forms of pulmonary hypertension. When we look at the prevalence of connective tissue disease, PAH, if you can see in your left side, this is the Revere Registry, which is the United States-based observational cohort for patients with pulmonary arterial hypertension on right heart cath. As you can see, among patients with group 1 PAH, 50% were associated PH, and from those groups, the leading cause was connective tissue disease, which represent almost 50% of those associated PH. On the right side, this is our local data from Prince Sultan Military Medical City, looking at group 1 PH. Around 49% they have associated PH, and connective tissue disease, we find it represent the second common causes of the associated PH, representing 30%, following the congenital heart disease PH. Not only PAH is one of the leading cause of mortality in patients with systemic sclerosis. Unfortunately, patients who had scleroderma-associated PH, usually they tend to do worse compared to other forms of connective tissue disease, pulmonary hypertension, and other forms of PH. In fact, 8 to 12% of patients with scleroderma will develop pulmonary hypertension. And in some reports, 15 to 20% they will develop pulmonary hypertension. Scleroderma is one of the most common connective tissue disease-associated pulmonary arterial hypertension and represents 75% of cases of CTD-PAH. As you know, scleroderma can affect the lung, heart, and the kidneys, which can all lead to pulmonary hypertension. And scleroderma by itself causes changes in the structure and function of cells that are involved in the development of pulmonary hypertension. So I just showed you this figure a while ago, and I would like to come back to this to show you how scleroderma might be challenging in terms of classification and diagnosis. Patients with scleroderma are at higher risk of getting pulmonary arterial hypertension, CTD. They can have a rare form of pulmonary arterial hypertension as known as pulmonary veno-occlusive disease. Those patients usually they tend to do worse when they're treated with pulmonary vasodilator, as they are prone to have pulmonary edema, and they do have some special characteristic findings in the CT chest that are different than associated PAH. Patients with scleroderma can have chronic lung disease, in particular interstitial lung disease that might lead to pulmonary hypertension. They can have a left heart disease, and it is very common for patients with scleroderma to have diastolic dysfunction that will lead to pulmonary hypertension. They can have chronic clots in their lungs that will lead to pulmonary hypertension. And they can have different organ involvement, like renal disease or other organ involvement that will lead to group 5, which is a pulmonary hypertension with unclear or multifactorial mechanism. So when we take a closer look about the natural history of the disease, in both diffuse and limited systemic sclerosis, we tend to see pulmonary arterial hypertension is usually as a later complication compared to interstitial lung disease, which usually, as mentioned by Prof. Sendo, it's an earlier complication. And when we take a look about the patterns of mortality, back in 1970s, the leading cause of death was renal crisis, and there is a major shift in terms of the mortality towards pulmonary fibrosis and pulmonary hypertension in most recent data in early 2000. So how do we diagnose the disease? So based on the latest 2022 ESC-ARS and the 7th World Symposium on Pulmonary Hypertension that was held last year in Barcelona, the recommendation is to go for annual echocardiography, annual pulmonary function test, including diffusion capacity and annual blood work. And this is only specific for patients with scleroderma. This is not applied for other patients with connective tissue disease, PAH. So what we look for, when we look at the pulmonary function test, we're not only looking at the spirometry, but we do a full pulmonary function test, including spirometry, lung volume, and diffusion capacity. And we are looking into a drop in the diffusion capacity for carbon monoxide of less than 60%. We also look at the ratio of forced vital capacity to diffusion capacity. We do echo to look for signs of elevated pressure in the lung, especially looking for the TR velocity, abnormal size, shape, or function of the heart chambers, and presence of pericardial effusion. We also look annually into some of the blood work, such as an elevated NT-proBNP or BNP or elevated uric acid. So our aim is to screen yearly before patients having symptoms. As you know, detecting those patients at earlier stage, their response to therapy is better, their survival rate is better. So we have multiple methods to apply this. We have the DETECT algorithm, which is an online app that you can perform. It has two steps. The first step, which is non-cardiographic, echocardiographic parameters, comprise of the pulmonary function, current telangiectasia, serum and autoantibody, serum NT-proBNP, urate, and ECG, and it will guide you if you have a score higher than 300 to refer a patient for echo. In the step 2, we look at the echo parameter, which is the right atrial area, and the TR velocity. And if you have a total score of more than 35, then a referral for right heart cath is recommended. When these apply to the new definition of pulmonary arterial hypertension, there was no major changes in terms of sensitivity. Actually, the sensitivity has a slightly dropped from 95 to 87%, and the specificity remains stable over 50%. Another method to screen for patient was proposed by the Australian Scleroderma Interest Group. So as you can see, it's simpler than the DETECT algorithm. It's using few parameters. It has two main components, component A and component B. Component A is mainly pulmonary function test, looking at the DLCO less than 70%, plus the forced vital capacity to DLCO ratio of more than 1.8. And component B is looking only at the blood, the NT-proBNP. And if you have a result of 210 or more, that's considered to be positive. If any one of these, component A or B, were positive, then a referral for pulmonary hypertension specialist to further investigate and possibly end up by right heart cath. If both are negative, then you will be relaxed and do screening annually. So pulmonary hypertension can only be diagnosed with right heart catheterization. You will not know if you have a PH or not without doing the right heart cath. You will not know what kind of pulmonary hypertension do you have and what is the best things to treat it. This should be done in an expert center to get the right numbers. And in terms of going to the treatment of PH, as I said earlier, it's very important to mention the grouping. So properly classifying your patient into these groups will guide your therapy. If you have a patient with group 1, group 3, group 4, there are medication are available and other medical intervention are available. But if you have a patient with group 2 or group 5, we should focus on those diseases and not only the pulmonary hypertension. We look at the patient preference as medication for pulmonary hypertension has different route of administration. We have oral pills, we have inhaled, and we have injections. Other consideration to keep in mind is the drug interaction and the cost, etc. And it's really important to know the severity of the pulmonary hypertension in light to guide your management strategy. So when you diagnose your patient as having pulmonary arterial hypertension group 1, we usually do the 1-year estimated mortality. So as you can see in the graph, we have 3 color coding, and based on that, we will classify our patient into which groups he fall. If the patient with pulmonary arterial hypertension associated with connective tissue disease, treatment of the underlying condition according to the current guideline is recommended. And in patient with pulmonary arterial hypertension associated with connective tissue disease, the same treatment algorithm as for patient with idiopathic pulmonary arterial hypertension is recommended. So in the most updated guidelines that was proposed in the World Symposium on Pulmonary Hypertension, in the past 2 decades, we have 3 famous treatment pathway. We have the endothelium pathway, which has bosentan, ambrisentan, and macitentan, all are oral medication. We have the nitric oxide pathway, which is sildenafil, tadalafil, and riociguat, and they are all oral medication. And we have the prostacyclin pathway, the oral medication selexipag, the inhaled iloprost, and the parenteral or sub-Q injections, epiprostenol and treprostinil. And last year, we have a new pathway that was approved by the FDA, which is the activin BMB pathway, specifically for medication sotatercept, which is given as a sub-Q injection every 3 weeks. So whenever you classify your patient as having pulmonary arterial hypertension, as I mentioned earlier, you will risk stratify your patient. If the patient fall into the high-risk group, then you have to hit hard with multiple medication, including the parenteral prostacyclin. If your patient is not in a high risk, then you can start your treatment with a combination oral therapy of ERA and PDE5 inhibitors. And after that, we do a quick follow-up in the next 3 to 4 months to see, because our aim in treating patients with pulmonary arterial hypertension is to put them in the green zone. So the continuation of initial therapy. If they tend to progress, then adding further therapy until we reach the maximum for medication, and at the end, also lung transplant evaluation. So for the sake of time, I just mentioned that you will go. There is another general measure for a patient with pulmonary hypertension. You have to avoid pregnancy, consider oxygen administration, immunization, diuretics, low sodium and weight daily, and iron supplementation. So my take-home messages is pulmonary arterial hypertension is defined by a mean pulmonary artery pressure more than 20 millimeter mercury, pulmonary capillary wedge pressure of 15 millimeter mercury or less, and pulmonary vascular resistance of more than 2. Scleroderma is the most common connective tissue disease associated with PAH. Right heart cath is the diagnostic gold standard for pulmonary hypertension. Different forms of PH may occur in PAH connective tissue disease patients and may even coexist. Yearly screening for PH and systemic sclerosis is recommended. PAH is associated with lower diffusion capacity for carbon monoxide and higher FVC-DLC ratio. Early proactive treatment is recommended using combination therapy when appropriate, and the overall goal of PH therapy is to achieve low risk status. I would like to conclude and thank you for it.
Thank you, Dr. Abaidallah, for the wonderful talk. We'll open the floor for discussion. Please, if you have any question, raise your hand, and the one mic here.
Thank you for all speakers. So my question to Prof. Sendo. Prof. Sendo, I would like to share one case of scleroderma who developed most of the complications, scleroderma, antisinal, ILD, UIP pattern, and chronic kidney disease that found to be interstitial fibrosis rather than ANCA or glomerulonephritis. She have a strong positive antibody, and she has recurrent pericardial effusion that, we tend to treat it with small dose steroid, but she have recurrent. And her, the ILD is progressing by the spirometry parameter. So my question to you, with such cases, which medication that you would like to go? Because she is on Celsipt and she is on nintedanib for the ILD. Interestingly, she found also to have diverticulosis, where maybe tocilizumab is contraindicated for her, case. So would you go for rituximab for this serositis with autoimmunity, or you will go for cyclophosphamide, being more study in scleroderma with all these systemic involvement? Thank you so much.
Thank you for that really interesting case. What's provocative about that case is the pericardial effusion. Pericardial effusions are not typical of systemic sclerosis, nor is it typical of interstitial lung disease. So one thought would be, does she have something else in terms of, does she have overlap syndrome with, say, lupus? Because we do see scleroderma lupus overlap.
leukoderma, if you will. So that's one consideration. The other consideration is concomitant pulmonary hypertension. When we see advanced pulmonary hypertension in the setting of systemic sclerosis, you can see pericardial effusions, and the unique consideration that my colleague spoke about earlier is the presence of pulmonary veno-occlusive disease. So if you see pericardial effusions in a scleroderma patient, one would consider concomitant pulmonary veno-occlusive disease with the ILD. The easier option to treat is if they have overlapping scleroderma lupus, because the options that you described would be the considerations, or similarly if they just had plain scleroderma and bad luck with having a pericardial effusion. So rituximab would be a consideration, and cyclophosphamide would be a consideration. I guess really here it would be a question of age. If she's a young woman, I think I would preferentially go for the rituximab and try to avoid the cyclophosphamide. However, the patient panel from the ILD guidelines told us that if they're a young woman, they still would consider cyclophosphamide, knowing that it might affect their fertility if it means that it might be a life-sustaining therapy for them. Whereas if it's a complication of the pulmonary hypertension, or specifically pulmonary veno-occlusive disease, I don't think that there's actually a role for additional immunosuppressive therapy. In the setting of PVOD, the best thing for her would be a lung transplant.
Excellent.
I'm not sure if my colleague has other comments.
Yeah, thank you both speakers for excellent presentation. My question for Prof. Sando, regarding the first line of therapy, we know is the MMF. I surprised in rheumatoid arthritis, we put number 2 is azathioprine, while tocilizumab is not there, only for complicated. While we we prefer usually as a rheumatologist tocilizumab as a first line or a second line at least in such a patient.
Thank you very much for that important and controversial question. So those of you who may know, the American College of Rheumatology posted all the figures that I shared with you on their website, and then the manuscript had to go through the peer review process with over 100 reviewers, so it took almost a year before the actual manuscript was published. And so some not so nice social media trolls said the same question, but in a nasty way. And so they wrote an article about me called "What Was She Smoking?" And so the question was, why did the American College of Rheumatology recommend Imuran for the treatment of ILD in the setting of rheumatoid arthritis? And so the reason is there is low certainty of observational studies to suggest that azathioprine can prevent progression. It's not great for improving disease, but at least it prevents progression. And in the North American context, or at least in the American context, not everybody has healthcare coverage. So while we would prefer rituximab and tocilizumab, there is a not insubstantial subset of the American population that has no healthcare coverage and would not be able to afford a biologic. Now, cyclophosphamide is an option, particularly if it's IV, because IV cyclophosphamide is often administered in a hospital day unit. And in that situation, the cost of the cyclophosphamide is paid by the hospital. It comes out of the hospital budget. Whereas if you prescribe oral cyclophosphamide, the patient has to pay. So then, if you're stuck in what we call the working poor, people that are working but don't have private insurance, but yet they don't have enough money to pay for expensive therapies, azathioprine is an old, inexpensive therapy. So the voting panel felt that it's better to offer them something than nothing. So that menu of options is not necessarily an order of prescribing. It doesn't have to be number 2. It's just a menu that you can choose from. The vast majority of rheumatologists will never pick azathioprine for the management of ILD, but at least we have an option for the working poor.
Yeah, it's great, but they didn't write even tocilizumab in the first option.
Yes, okay, so that's an excellent point. So if you look at the manuscript, in fact, it's neither recommended for or against. There was considerable argument, if you will say, at the voting panel, because in systemic sclerosis, we have secondary data showing that the FVC can improve. But we don't have similar data across the other diseases, MCTD, rheumatoid arthritis, et cetera. And so the pulmonologists on the voting panel were unwilling to extrapolate the data from scleroderma or consider it as indirect evidence for utility of tocilizumab in ILD. So that being said, it's a very subtle comment that I'm making here. They don't recommend for tocilizumab, but they don't recommend against tocilizumab. So if you were to ask me, what do I do in my practice? If a patient has active inflammatory arthritis with rheumatoid and they have and ILD, I use tocilizumab.
Okay, thank you.
Thank you, all the speakers. And my question to Professor Johnson, and it's very nice to find that a rheumatologist in the ILD guidelines, which does prove that the MDT is always important for that. Now, I'm a pulmonologist, and we have sometimes patients coming with connective tissue disease. During the screening, we find an ILA, which is interstitial lung abnormality. So those patients, they are not symptomatic, their PFT is normal, 6-minute walk test is normal, but ILA is there. And we heard earlier that we are now doing like hit early, hit aggressively. So what to do with such kind of patients? Thank you.
Well, thank you. I very much appreciate the subtlety in your cautionary note, because you're absolutely right. In the old days, when people used to screen with chest x-ray, you had to have moderate to severe ILD before it would even show up on an x-ray. But now that we have routine access to a high-resolution CT thorax, many sclerodermal patients will have a little bit of bibasilar fibrosis, but the absence of symptoms and completely normal PFTs. So in those patients, we do not actively recommend treatment. Many people will say, let's just watch and see, because some of those patients may never progress. And the risk of infection in those patients is really not worth the benefit, because we don't actually know if there's a benefit in those patients. So that approach of hit hard, hit early does not apply to scleroderma ILD yet.
Now, how we are going to follow? Only with using the HRCT, or we just apply the same rule with progressive pulmonary fibrosis?
Well, I guess the notion of progressive pulmonary fibrosis is not really a rheumatology term. It's mostly a Boehringer term for their clinical trials. You know, we just look for ILD and then look for progression. So, yeah, at this point, the ACR guidelines do not recommend hit hard or hit early.
Thank you very much.
For time's sake, we'll have one more question. Okay, go ahead.
Thank you. I have two patients, send them for autologous stem cell transplantation successfully. And the third patient, I want to send her abroad to Duke University in the States. But she asked me, why don't we go for CAR T-cell therapy? So I need a comment on that.
So you're asking my thoughts on CAR T therapy versus hematopoietic stem cell treatment?
Yes, on scleroderma patients.
Okay, so I think that's going to be the major clinical trial of our time. I mean, the case reports looking at CAR T therapy are very provocative and exciting, but at the end of the day, they're still case reports. And in rheumatology, we have lots of experience of things that look good in animal models and things that look good in case reports, but when we get to the phase 2, phase 3 clinical trials, they don't pan out. So if you're asking me in 2025, February 2025, we have a more robust evidence base for hematopoietic stem cell transplant, so I think that is preferred over CAR T. I am an investigator, or my site will be an investigator in 2025 on the Novartis CAR T trial for scleroderma. So if you ask me in 2026 what I think, and maybe the answer will be different then.
Thank you.
Thank you very much. I just have a very quick question. Regarding anti-MDA5, I know it's a rare disease, but it hits hard because with the rapidly progressive ILD. Now, what are your thoughts, because the data is suggesting for subacute ILD and MDA5 to go with JAK inhibitors rather than the triple therapy that we hit hard and rapidly progressive. What's your thoughts?
Sure, so the American College of Rheumatology does support JAK inhibitors for the myositis-associated ILD. That's most typically where we see the MDA5 antibody, and so the American College of Rheumatology guidelines conditionally support the use of JAK inhibitors.
Thank you.
I think you had a question to ask Khalid, right?
Yes, I do, actually. May I ask
Yeah.
my question? Okay, so you presented the data on the sotatercept for pulmonary hypertension. We rheumatologists are very well versed in the use of biologics, but maybe not that one. Can you just explain your thoughts or explain the use of that biologic for pulmonary hypertension?
So that was really interesting, targeting those biological therapies, especially the activin BMBR, because as we know, remodeling is one of the main pathways of targeting the treatment of pulmonary hypertension. In the past, they were targeting usually the pulmonary vasodilator, so the depletion of the nitric oxide, the endothelin resistant antagonist pathway, and targeting those biomarkers seems to be doing a balance between the BMPR and the activin receptors. So that's not only causing pulmonary vasodilator, but also restoring the remodeling of the vessels, and that's sotatercept was worked well with these mechanism.
Thank you. Excellent. Thank you. Our speakers was very wonderful session, and that will conclude our discussion for this session. Our thanks extended to the organizing committee for this successful session.
Halford.
دكتور مهد ماكنزي.
Prof. Sandhu Johnson. دكتور خالد عبيد الله.
So, ladies and gentlemen, we will now move to the Satellite Symposium by AbbVie. It's entitled Stringent Disease Control in Rheumatology, and it will be presented by Dr. Ziad Al-Zahrani. Dr. Ziad is a senior consultant rheumatologist with more than 25 years of experience in rheumatology at King Khalid National Guard Hospital in Jeddah. So please welcome me in joining Dr. Ziad for the Satellite Symposium.
Thanks, Dr. Walid, for this introduction, and I would like to thank AbbVie for inviting me to participate in this symposium, and the organizing committee for inviting me to participate in this conference as well. So my talk is going to be on the the stringent disease control for rheumatology. And this is the disclaimers here and my disclosure as well. And let's talk now about the treatment target for remission or low disease activity in rheumatology in general. So as you can see here that the ultimate goal in rheumatoid arthritis, for example, is to achieve remission. Because certainly when you achieve remission, you will end up having better outcomes for the patient in terms of fewer infection risks, improved mental health, and prolonged absence of the symptoms. There will be also improvement in the less joint damage, fewer orthopedic surgeries, and improved cardiovascular health, and also improved quality of life for those patients. So we always strive for achieving remission for those patients with rheumatoid arthritis. In fact, if you look into all the recommendations, the international recommendations for rheumatoid arthritis, they all endorse remission. And if the disease is longer standing, then probably low disease activity would be an alternative approach for managing those patients. So you can see here the Treat to Target 2014 recommendations, the ACR 2021 guidelines, and the EULAR 2022 recommendations. They all endorse remission or low disease activity as a target for those patients. Now, despite actually the available guidelines and the advances in the treatment, unfortunately, most RA patients do not achieve remission. And there are certainly reasons for this, including, for example, late treatment for those patients when the disease is well established, or probably the incompliance from the patients themselves, or probably the drugs that we use are not that optimal. So that's why we need to treat early and aggressively in order to achieve remission and prevent the disease progressions. You can see in this study, for example, 78% and 76% had not achieved DAS28 less than 2.6, which is remission, by 12 and 24 months respectively, indicating that there is still unmet needs in the treatment of rheumatoid arthritis despite the whole advancement in the treatment. And so certainly achieving early remission and sustained remission is a goal and an aim that we should look for. And that can be possible, in fact. Look into this study, for example, here, where if you treated those patients early and aggressively, you were able to achieve remissions in the first 2 months. 28% of the patients achieved remissions. And those who achieved remission early, they were able to sustain it. You can see 75% of the patients had early remission that is sustainable over time, which is, in fact, this Chinese study indicating that patients with RA who achieved early remission were 2 times as likely to sustain it for more than 6 months were possible compared to those who did not achieve early remission. So achieving remissions early was associated with better outcomes in patients with rheumatoid arthritis in terms of less pain and also improvement in the quality of life and function as well. So we really need to achieve that goal. Again, this is a study, for example, that tells us if you use appropriate treatment, you are more likely to achieve remission. For example, the use of upadacitinib plus methotrexate achieved significantly greater remission rates versus adalimumab plus methotrexate at week 12, and those patients who achieved remission were able to sustain it for 5 years. So this is really an indication to tell you that these targeted therapies, for example, they give you a better outcome when you use them early and aggressively. So again, this is the same message that we are trying to stress for it, which is striving for clinical remissions and, in fact, to do it early. So we've seen from the randomized controlled trials that the JAK inhibitors, for example, were able to give you good outcomes when you look into controlled clinical trials. But we also look into the real-world effectiveness studies. So this study, which is the observational uphold study, which included also some of the Middle Eastern countries, Saudi Arabia, Kuwait, and Emirates, almost 43.9% achieved DAS28 CRP remission at 6 months. So this is really great result when you look into the real-world effectiveness studies. Again, the efficacy is really important. We know this. But it's not only the efficacy, it is also the safety, which is really important as efficacy when you choose a treatment approach for your patients. Now, looking into the use of the JAK inhibitors, for example, in this case, upadacitinib, there were no events of opportunistic infections or active tuberculosis or major adverse cardiovascular events, venothromboembolic events, hepatic disorders, gastrointestinal perforations, and these other, outcomes, indicating that even in our area, these drugs were actually safe and effective, as we have seen. Maybe a little bit of increased risk of herpes zoster, but now we have the vaccine which can basically reduce that side effect. Now, the majority of the patients with rheumatoid arthritis achieving treatment targets at 6 months with upadacitinib maintain the response at 12 months. Look into this study, for example, here, where you see almost 46% of the patient, they achieve DAS28 CRP remission at 6 months. Those who achieved this result were able to maintain it for 12 months. In fact, almost 80% of those patients were able to have a sustained remission over 1 year, which is a great result. Now, we have seen the Uphold study, including also our region, but we now see another real effectiveness study from the Canadian aspect. This is a close-up study which confirmed actually the real safety and effectiveness of upadacitinib in a broad range of Canadians. And you can see whether the patient had used previous biologics or they have used previous even targeted synthetic DMARDs. They were able to achieve responses when it comes to using upadacitinib. Almost 63.5% of the patient achieved remissions, irrespective of the prior treatment, including the JAK inhibitors. So now, I think you're now aware about the concept of immune-mediated inflammatory disease. We've seen this concept in the case of, for example, anti-TNF. We know that TNF plays a role in the pathogenesis of many rheumatic diseases, including rheumatoid arthritis, ankylosing spondylitis, and psoriasis and psoriatic arthritis. And the same things has been shown also with the JAK-STAT pathway. So the JAK-STAT pathway also plays a role in these diseases. Therefore, now we see evidence that these drugs basically work, whether in rheumatoid arthritis or other immune-mediated inflammatory diseases like, axial spondyloarthritis or psoriatic arthritis as well, even inflammatory bowel disease. So now let's look into and shift the gears a little bit to the axial spondyloarthritis. And as you know, these inflammatory diseases have, widespread, diverse clinical manifestations involving different domains. You can see that they have spinal involvement as the main, domain involved. But you can have also peripheral arthritis, enthesitis, dactylitis, and they can be also extra musculoskeletal manifestations like psoriasis or inflammatory bowel disease or uveitis that can be seen in these patients. Now, despite also the treatment availability of many options, including the biologics, unfortunately, we still have unmet needs in the treatment of axial spondyloarthritis. You can see that 75% of the AS patients do not achieve SDAS low disease activity, which is one of the targets, our targets for remission in those patients, and that is still not achieved. So there is still a treatment gap in these situations. As you are aware, we have this spectrum of axial spondyloarthritis, which is ranging from the non-radiographic axial spondyloarthritis to the radiographic axial spondyloarthritis. And there may be some common, manifestations in all of these, domains. For example, the non-radiographic axial spondyloarthritis, they may be more common in the females compared to the radiographic, which is more common in the males. The radiographics also have more HLA-B27 positivity. They have also high elevated CRB and also the radiological changes. Unfortunately, in the setting of non-radiographic axial spondyloarthritis, you might have a delay in the diagnosis because you might not see the radiographic changes in those patients. And that's one of the things that differentiate the two entities. Now, achieving stringent disease targets can help patients reach their goals of therapy, including, for example, maximizing the health-related quality of life, which we always look for, control the symptoms and inflammation, prevent structural damage, and also preserve the function. These are really important goals that we need to achieve. And we always look into targets in our patients with rheumatic diseases. In this setting, for example, in the axial spondyloarthritis, we look for the SDAS low disease activity for, ankylosing spondylitis, the radiographic and the non-radiographic aspect. And for the psoriatic arthritis, we look for MDA or DAPSA-LDA, for example. Targets may differ from patient to patient, and a target should be a shared decision between the patient and the rheumatologist. I think you are aware about the updated EULAR guidelines in 2022, which recommended the TNFI, interleukin-17 inhibitors, and the JAK inhibitors as first advanced therapies for those patients. So if those patients have purely involvement of the axial spine, then any of these treatment can be an option for your patients. However, history of certain extramuscular skeletal manifestation may favor one drug over the other. For example, if you have uveitis or inflammatory bowel disease in association with the axial spondyloarthritis, then anti-TNF monoclonal antibodies would be an option in those patients. And if you have widespread psoriasis, skin psoriasis, then probably interleukin-17 would be an option in those patients. Now, let's look into the efficacy of upadacitinib in those patients with axial spondyloarthritis, and you can see that high proportion of the patients on upadacitinib achieved SAS40 across the axial spondyloarthritis spectrum through week 52. So whether you have radiographic or non-radiographic, you will be able to achieve good SAS40 responses, and irrespective of previous biologic DMARDs used with rapid onset of action starting from week 2. So now we have really effective and a drug that can give you a rapid onset of action, which is really important for this disease, which we still have some unmet needs for its therapeutic armamentarium. Again, you can see that low disease activity achieved in more than 50% of the patients in upadacitinib across the axial spondyloarthritis spectrum through week 52. And whether you have non-radiographic or radiographic axial spondyloarthritis, we still have efficacy and also a persistent treatment effect over time, as you can see here. Upadacitinib change from the baseline pain symptoms in AS is sustained through week 64. So what type of pain you are having, the back pain, the nocturnal back pain, and also the other features, you might have really efficacy on this aspect. Upadacitinib demonstrated improvement of the pain, the function, and health-related quality of life and inflammation through week 52. So now, really, in most of the trials, they are trying to include the patient-reported outcomes as one of the assessment outcomes in the trials. And we see now evidence that it works basically on those aspects when it comes to the upadacitinib treatment. Development of extramuscular skeletal manifestations with upadacitinib was generally low. So if you start those patients on upadacitinib, you are less likely to have development of uveitis or inflammatory bowel disease. So it means that it works basically in those situations. So upadacitinib long-term safety is important, as we've said. And if you look into the data, for example, we have now evidence up to 7.5 years that upadacitinib 15 milligrams demonstrated generally consistent safety profile with no new safety risks identified, encompassing almost 50,000 patient years of clinical data. And certainly if you look into the different treatment options, whether when you're talking about rheumatoid arthritis or psoriatic arthritis or axial spondyloarthritis, we are seeing consistent, efficacy and also safety data. Maybe a little bit of an increased herpes zoster, but we've said that now we have effective vaccines that has to be used actually even before starting the JAK inhibitors. So with this, I end my talk, and thanks a lot for listening.